She has done a GNM from the Nazareth Hospital and passed out in the year 2004. She has also done a post-basic from the St. John Medical College, Bengaluru, and passed out in the year 2007. She has a 15 years of working experience, and she is a member of Trained Nurse Associations of India and Catholic Nurses Guild of India. She has also taken, I think many of you are also know her because she has also taken our first session. And today we have a guest speaker, Madam Salam Premila Devi. Ma'am is working as a tutor in a College of Nursing, Nigrims. Ma'am has done a BSc Nursing from the Regional College of Nursing, Guwahati, Assam, and passed out in the year 2002. She has also done a Masters of Nursing in Child Health from the Nehu College of Nursing in Shillong, Meghalaya itself in the year 2021. When we are talking about her working experience, she has total 21 years of working experience, out of which 6 years she has worked in a clinical area and 15 years she has a teaching experience. During her entire career, she has done one publications and she is working under a 2 project and has attended a simulation training for master trainers in HTT University, Guru, organized by INC. She is also a member of SOMI and Indian Associations of Neonatal Nurses. So thank you once again, ma'am, for joining with us. So now I would like to hand over the platform to our presenter. As usual, first we will do our presentations. Then after the presentations, our guest speaker will say something about our topic. Then we will start the discussion session. Okay. So over to you, Sis Verity.
Good afternoon, everyone. Thank you, Ma'am Nanuka, for the introduction. And I would like to welcome our guest speaker of today as well, Ma'am Salam Devi. And then I also welcome all the participants of today's session, since today is the second last session. So we will have a little of the interactive session, since the topic is a common topic for everyone. So today's topic is about referral and pre-referral stabilization transport. When you talk about referral, it is a very familiar procedure or familiar word, a term to us, especially us working in the hospital setup, where patients are being referred from one center to another center, from a primary center to a higher center. Okay, so what we'll talk about in today's topic is all about what procedures we follow for during a referral of a patient and before the patient is being referred. Okay, it is not only we will not only talk about the patients being referred out from one hospital to another, but it is also a referral which will take place within the hospital between departments. Okay, so I start with the session. So the meaning of referral. Referral means a system of transferring cases which are beyond the technical competence of one infrastructure to a higher level. So it only means that when patients are not being able to handle due to unavailable facilities, they are being referred to a higher center or to a higher level. Then this site is covering. Okay. Okay, thank you. The second point are the purposes. Why are patients being referred? The first point is to provide need-based comprehensive care. Need-based comprehensive care means that the whole health of the patient is considered. Okay, by referring a patient to a better center, the whole health of the patient is being considered. That is, the physical, mental, and the social aspect of the patient is being looked after in the higher center. Then the second purpose is to help people avail specialized services available at higher center. So to help the patient use the specialized services at the other center. The third point is the steps of referral process. So what are the steps we follow during the referral process. First is establish the need for a referral. The medical team in the hospital or in the primary center looks into the need of the patient for the referral. For example, this patient is a patient with recurrent seizures. Okay, the child comes to the primary health center with recurrent seizures, and the seizure may not be it may not be a simple febrile seizure, but a chronic seizure. Okay, so what happens is the team in that center refers the child to a higher level where the availability of investigations are better, the availability of the equipments and facilities are better. So they establish the need, they look for the need. Does the patient need to be referred or not? Okay, then they set objectives for the referral. They set goals for the referral. Then patient's party decides to use or not to use. Okay, so after the team has decided to refer the patient, they will have to seek the patient's party consent first, whether the patient's party accepts the need for the referral or not. Okay, then facilitate or coordinate referral. So when the patient's party has accepted, okay, has decided to take part in the referral, what they do is the team starts putting into action. Okay, they put into action and they start coordinating. For example, a child has a very sick child. Okay, the one with recurrent seizure wants to be transferred to a higher center, maybe to Ganesh Das Hospital first. Okay, what they do is from the primary health center, they coordinate. They contact with the Ganesh Das Hospital people, whether beds are available, whether doctors are available, okay, whether the facilities are available or not for the condition of the child. Then the evaluation and follow-up is done for the child. So these are the steps of referral process. Then coming to the referral systems in India. In India, the referral systems stepwise comes from the sub-center. Then from the sub-center, they first proceed to the primary health center. If the primary health center, the facilities are not available, they go to the community health centers. Then the sub-district center, the district level, the tertiary or the higher level center, that is the tertiary health facility, and the later on to the super specialty hospitals. So see, these are how the referral systems work in India. Then coming to the integrated case management process. So this process has been devised by the integrated management of neonatal and childhood illness, okay, or the IMNCI. Okay, this case management is this management process is based upon, it mainly deals with how a sick child is referred to according, and the sick child is being classed under the 3 different colors or the triage. This is the triage chart. The pink chart, the yellow, and the home management, or the green chart. Okay, the pink refers to the severity of the patient. The child, or the yellow is the mild, or is the moderate, and the green is the mild. Okay, now we look on to this process. What does this process talk about? First, in this first column here, they check for the danger signs, that is convulsions, lethargy, inability to drink, breastfeed, and vomiting. So according to the danger signs, the child is being classed under the different colors, or the triad chart. Okay, the severe, the moderate, and the mild. Then even the symptoms, if the child is having cough, difficulty in breathing, diarrhea, fever, ear problems, these are being put under the triad chart colors again, and the assessment of nutrition, immunization, and potential feeding problems as well. These are also classed according to the triad chart. So in the first chart, you see the first column, that is the pink color or the severe column. This, when the child is classed under the pink column, okay, or the severe column, that means the child is needs to be urgently referred outside, okay, to a higher center. Are you clear? That is the pink chart. And in the yellow triage, okay, or the moderate triage, here the child is being classed here. The child can still be treated under the OPD basis, okay, and under the home management or the green triage, green color triage or the moderate triage, the child can be sent home and can be counseled for home management. Okay, so that is the integrated case management process. This is where this process is mainly to assess the severity of the illness of the child, and according to the severity of the illness and symptoms of the child is referred to the higher center. Then coming to the next, that is the components of a referral system. What are the components? You have the first one is referral practicalities. In the referral practicalities, once a child is being decided to be referred outside, is being planned to be referred outside, there should be the outward referral form. Okay, the outward referral forms. Then the communication with the receiving facilities. Okay, the one who receives the center who receives the child should be communicated. Then information to the patient's party. Whatever is being decided, whatever is being discussed about the child or about the patient should always be communicated to the patient's party. Okay, then referral register, whatever the details of the child, all the details of the referral should be entered in the referral register. Then we come to the next point of the component, that is receiving facility. In the receiving facility, that means the child has been transferred to the, as you see here in this picture here, the child has been transported to the higher center. So the receiving facility receives the child, okay, receive the client with the referral form. So the receiving facility goes through the referral form, goes through the history of the child, the treatment which was given in the previous center. Okay, then they start treating the client and they start documentation. Okay, and the next part is they plan for rehabilitation. Plan for rehabilitation means that they take care of the child and help the child get back, improve the abilities of daily living. That means they help the child get back to normal living or normal life. Okay, that comes under the receiving facility, where they receive the client with referral form, they treat the client, document and plan rehabilitation. Then the third point is supervision and capacity building. Here in supervision and capacity building, it talks about the patient's party giving a feedback about the referral system and the place where they were being referred to. That is about the supervision and capacity building. Then coming to pre-transfer stabilization and preparation. In this pre-transfer stabilization and preparation, it talks about the patient, how to assess the patient before transferring the patient to another center or before transferring the patient to another department. Okay, when we have to transfer a patient to another department or to another center, when it is decided, we just don't immediately transfer the patient without assessment of the patient. Okay, we have to stabilize the patient first, then do the transfer process. Okay, so first, what is the first assessment in pre-transfer? The first is the airway. Okay, when you look at the airway, what do you assess for in the airway? You check if the airway is clear or not. Okay, assess for labored, any presence of labored breathing, any presence of use of accessory muscles during breathing. Okay, Then any presence of cough in the child. Okay, that is the how you check for the airway clearance. Then can the child speak or can the child cry? Okay, then presence of airway noises. That is presence of snoring, stridor, wheezing, gurgling sounds. That is what you assess for in the airway noises. Then we do the management accordingly. If the airway is not clear, we position the child properly. We perform suction, oral and nasal suction accordingly, according to the need of the condition of the child. Then coming to the next assessment, that is B, or breathing. In breathing, we first assess for the respiratory rate of the child. Okay, the respiratory rate of the child, looking into the presence of tachypnea or bradypnea. Then the breathing pattern of the child, or whether the breathing pattern is regular or irregular. Then we look for the chest symmetry on inspiration and expiration. Is the symmetry of the chest, both sides, is it expanding equally or not? If the chest is not, the chest symmetry is unequal, it may show due to a decreased in ventilation in the child. Then the use of accessory muscles, as I have mentioned earlier, it may be due to the presence of respiratory distress. Then we move on to the circulation, or C. In circulation, we first assess for the color of the color of the skin or the mucous membrane of the child. Okay, any presence of bluish discoloration or cyanosis. Then presence of sweating in the child. Is the child sweating or not? Then heart rate, presence of tachycardia or bradycardia. Then we look for the CRT, that is the capillary refill time. In capillary refill time, how we assess is that we press one finger on the child's sternum or forehead for 5 seconds, and then we count. Okay, we start counting, and the prolonged and the normal CRT in a child is usually less than 2 seconds. And then if the CRT is prolonged, it may show circulatory insufficiency, or the child may be in shock or dehydration. Then the next part we look for in circulation is the blood pressure in the child. Coming to the next part, that is the assessment of D, or disability. In disability, it all talks about the neurological examination or the neurological function assessment. Okay, here in disability, we assess for the level of consciousness of the patient. And when we have to assess for the level of consciousness of the patient, we look for AVPU. Okay, A is for where the patient is awake. V is whether the patient responds to any verbal commands. P is whether the patient responds to painful stimuli. And U is where the patient is unresponsive. Okay, that is what we look for in disability, or in the level of consciousness. A, V, P, U. Awake. Then V is verbal commands. P is painful stimulus. And U is unresponsiveness. Then coming to the next part in disability, the Glasgow Coma Scale. Glasgow Coma Scale is used to assess a person, a child, based on the ability to perform eye movement, based on the ability to speak and to move. And the eye, it all talks about the eye opening, the motor response, and the verbal response. And the total score is 15. And in pediatrics, the GCS scale is slightly different from the adult, because in pediatrics we have different age groups, from newborn to infant to toddlers, preschoolers, schoolers. So it differs when it comes to newborns and infants, where they are not able to verbalize. Okay, they are not able to speak. So the GCS scale rating for them is a little different, but the total is the same as 15. The best score is 15, then below 8 is comatose, and 3 is unresponsive, or 3 is, yes, unresponsive. I hope you're clear with disability. It all talks about the neurological functions. Then coming to the exposure, that is the E. When you talk about exposure, it mainly relates to the what you see over the skin. Okay, so you inspect for any presence of bleeding in the child, presence of rash, bruising, presence of any signs of infection in the child, swelling, scars. Then check the child's body temperature for any presence of hypothermia or hyperthermia. Then you also look for any signs of fracture in the child. Okay, that is all we look for the exposure. So transfer, stabilization, and preparation talks about the assessment of the airway, breathing, circulation, disability, and exposure. Coming to the types of patient for transport. What are the types of patient we have for transport? Transporting a patient doesn't only mean we transfer or patients of or seriously ill patients are being referred. Transport of patients can be based on 4 categories. Okay, level O. Patients who can be managed at the ward level. So patients who are being transported from one department to another, or from one hospital, or from one center to another, it can be different types of patients. Okay, first is the patients who can be managed at the level of the ward. That means patients who don't need close observation as such. Okay, then level 1. Patients at risk of deterioration during transfer. These may be patients receiving oxygen. Okay, these may be at risk of deterioration, or maybe with the misplacement of the nasal prong or the face mask, the child may, the saturation may drop down. Then level 2, include patients who require observation for intervention. That is, these refer to HDU patients. HDU patients are patients who require more close observation. They are just one step lower to ICU patients. Then these patients need more intensive observations. They require more of nursing observation and nursing care. Then the last level is include patients with requirement of advanced respiratory care during support. These are patients, mostly ICU patients, or patients requiring mechanical ventilator support. So these are the 4 levels of the types of patients for transport. Then coming to the types of transport. Previous one. This one? Yeah. It's not coming. It will not come there. It will come. It's not coming. It's not coming. And it will come. Maybe if we minimize this.
No, it's I got disconnected. Oh, I got disconnected. Okay, you just tell. We will just tell them.
Okay. Now we come to the next point. Sorry for the interruption. There's a slight disturbance in the slide. Okay, and then we come to the types of transport. Here in the types of transport, we talk about the intra-hospital transport, that is within the hospital, transport of a patient within the hospital. Then inter-hospital, that means between the hospitals, and scene run. Scene run is from the non-medical site to the nearest hospital. Okay, when we talk about the intra-hospital, that means transport of patients or referral of patients within the hospital from one department to another. For example, a child in the pediatric ward has been diagnosed with maybe after doing an echo, the child has been the echo report has been found to be related to the cardiovascular disorder. Okay, so the child is being referred to the cardio department. Okay, that is the intra-hospital transport. So the referral is sent to the cardio department, and the department medical team comes to see the child and ask for a transport of the child to their department. Okay, so we transfer the child from pediatric ward to the cardio department. That is the intra-hospital. Then coming to the inter-hospital, that is referring a child from one hospital to another hospital. Then scene run. Scene run is from the non-medical site to the nearest hospital. Means, for example, maybe a passerby has met with an accident, and from there they take the patient to the nearest hospital available. Now we come to the next point, that is the factors to be considered when selecting mode of transport. So before we select the mode of transport, where the patient is to be transported here, or the patient is to be transported somewhere else to another center, what are the points we keep in mind? Okay, we look for the severity of patient's illness. If the child is if the child is to be referred to a higher center, okay, and the child is on ventilator, so the child cannot be transported in a simple vehicle. The child has to be transported in a well-equipped ambulance. Okay, so we have to check the severity and of the child's illness first, then look for the transport before looking for the transport vehicle. Then post-resuscitation stability. In post-resuscitation stability, it talks about the after resuscitation of the child. The child should be stabilized first, then the child can be transported to the other center. Then availability of vehicles. What are the type of vehicles for transport available? Then personal ability. Personal ability, it talks about the ability of the patient's party, how much they can afford. Then the weather and traffic conditions. Then the geography of the area, that is the location of the area to be referred. Then the safety. Safety is the area safe to be transferred or not, and the cost of the transport. These are the factors we consider for selecting a mode of transport. Then coming to the assessment, how will we recognize and assess a sick child? That is the pediatric assessment triangle. How we as a team recognize the sick child before and during transport of the child. The first part is the appearance. In appearance is tone. What do we look for in tone? In the tone, we look for the spontaneous, whether the child is moving spontaneously or not. We assess for what we call is hypertonia and the hypotonia. In hypotonia, we assess for the limbs of the child, whether the limbs are the stiffness of the limbs of the child, the ability of the movement of the child, whether the child is having difficulty in movement or not, and the presence of muscle spasms. Then in hypotonia, that we look for the floppy limbs, then the muscle tone of the child, the low muscle tone, then the difficulty in the child, difficulty in standing in the child, okay, and the instability of the child. That is what we look for in the tone of the child. We look for the movement. Just in one word, we look for the movement of the child. Okay. Then coming to interactiveness. In interactiveness, we assess for the alertness in the child and how the child interacts. Okay. Then consolability. In consolability, if we assess for the how the child stops crying with holding. Okay, if the child is continuously crying and if the caregiver holds the child, is the child consoled or not? Okay, how the child is being comforted by the caregiver. Then look or gaze. In look or gaze, we look for the maintenance of eye contact of the child. Is the child able to maintain eye contact or not? Then the speech and cry. In the speech, if the child is able to, if the child is able to speak, has attained speech, is the child does the child use appropriate speech or not? Okay, and if it is in infants and newborns, what is the type of cry? Is the type of cry normal or abnormal? Okay, that is what we look for the appearance. In appearance, we look for tone, interactiveness, consolability, look or gaze, speech or cry. Then coming to the second part of the assessment, that is the work of breathing. In work of breathing, we assess for the first point, that is the abnormal breath sounds. In abnormal breath sounds, when you talk about breath sounds, you assess for presence of wheezing, snoring, stridor, or grunting. Okay. Then the abnormal positioning of the child. What is the position? Does the child prefer a sitting position, okay, or a prone position, or a sniffing position? Then when we look for the next part, that is retractions, we look for the presence of the inward movement of the muscles of the chest during breathing in and breathing out of the child. And then we also look for the nasal flaring, that is movement of the nostrils during expiration of the child. That is the work of breathing. Then coming to the last part of the assessment, that is the circulation to the skin. In circulation to the skin, we assess for pallor, that is pale skin or in the mucous membrane. Then mottling. Mottling is the presence of patchy skin discoloration due to vasoconstriction. And then cyanosis. Cyanosis is the bluish skin discoloration of the skin or the mucous membrane. So that comes under the circulation to the skin, pallor, mottling, and cyanosis. Then coming to the next part, that is how a newborn is transport. Okay, newborn transport is very much different when it comes to transport of the other age groups. Excuse me. Newborn will be classed under babies within 28 days of life. 28 to 30 days of life are classed under group of newborns. So newborn transport is used to move premature and other sick infants from one hospital to a medical facility which has a neonatal intensive care and other specialist services. So many of the transport, this newborn transport, especially premature newborns, is very common. They are being referred from the primary health center to the higher center due to unavailability of facilities like radiant warmer, okay, and like incubator. So they are being referred to the higher center. Then what are the indications of neonatal transport? Why are neonates being transported? Okay, first is a neonate is being transferred to a higher center since it is a preterm infant with a birth weight of 1500 grams or gestation of less than 32 weeks. The second indication is respiratory distress requiring CPAP or assisted ventilation. The third, severe hypoxic ischemic encephalopathy. Then life-threatening sepsis. intractable seizures, and bleeding neonates. These are the indications of why a neonate is being transported to a higher center. Then coming to the next point, what are the reasons for transferring infants between hospitals? Why are those infants not being able to be taken care in the lower centers? First is no appropriate local facilities. For example, no unavailability of, as I have mentioned, unavailability of radiant warmers, of incubators, of CPAP. Okay, then no cots available locally. There may not be any beds available for the baby. Insufficient staffs available locally, example, pediatric surgeon or cardiologist. Unexpected delivery far from home. Okay, that is the these are the reasons for transferring infants between hospitals. There are no appropriate local facilities, no cots available. That means the beds may be full. Then insufficient staff, that is presence of specialists, and unexpected delivery far from home. Now coming to the next part, that is transport protocol or prerequisites. So what is the protocol we follow before transferring a patient from one center to another? First is informed consent from parents. Informed consent is very important. Nothing can be decided without the parents and the relatives' consent. Then confirm the vacancy and inform the approximate time of arrival. So if the child is, for example, a newborn preterm baby is has been delivered in the primary health center, and there is no availability. There is unavailability of an incubator or a radiant warmer. So what they do is they refer the patient to Ganesh Das or to Negrim. So before referring the child, they make sure whether beds are available or not. Okay, so they confirm the vacancy and the presence of bed. Then ensure that neonate is stable before and during transfer. Then transport team, there should be 2 members skilled in neonatal critical care, senior doctor and a neonatal nurse. Then coming to the transport equipments. So during transport of a sick child or a preterm child or any a preterm baby or a sick newborn, the transport equipments should always be available in the ambulance or in the vehicle for transport. First is the transport incubator with multi-channel vital signs monitor for recording temperature, heart rate, NIBP, oxygen saturation. Okay, that is the incubator. Then the second one, CPAP facility with nasal prongs and portable ventilator. As you see here in the first picture, it is the first picture here is the CPAP facility, a portable CPAP facility. Then to your corner, right corner is the transport incubator. Okay, then the left corner you see here up there, it is the the vital signs monitor. Then on the lowest left, you see the airway equipment, the suction devices, oral airways, back and mask laryngoscopes of different sizes according to the age of the child. Then the IV access and the line placement for the child. Then you have the common emergency drugs, which are supposed to be included in the transport equipment. So these are what the equipments which are supposed to be available in the transport vehicle. Then during the transport of critically ill patients, we may face many of the adverse events. That means there may be disadvantages during transport. Okay, first is lead connections. Second is loss of battery power. Third is loss of IV access, or the IV line may come out on the way. Then accidental extubation. If the child is with an ET tube, there may be an accidental extubation. Then occlusion of the ET tube. and exhaustion of oxygen supply. That means the oxygen supply may be completely, the supply may be cut off. Then physiologic deteriorations related to critical illness. The child may deteriorate. Then worsening hypotension in the child and hypoxemia in the child. These are the adverse events which may take place during the transport of the child on the way. Then, what is our role as a nurse in the referral service? The first role, make sure the referring center has been informed. The second, proper communication with the family members. The nurse should check the condition of the patient, whether fit to be shifted immediately or not. This is very important. Before shifting a patient, assessment should be done. Assessment and reassessment. And if the child is identified as not fit, the child is informed has to be informed to the doctor. Then collect all required documents and investigations of the patient before shifting, and check the referral form whether completely filled or not. So summary, excuse me. Call, arrange for ambulance, communicate to referral institute, quick assessment and stabilization of patient by transport team, anticipate problems likely to be encountered during transport, communication with receiving pediatrician. So call, communicate, quick assessment, anticipate problems, communication with receiving pediatrician, and handover. These are the important points we need to keep in mind while transporting a patient. So this comes to the end of today's presentation. I hope you have understood, or means you have at least taken some knowledge from here. If there are any queries or any anything you would like to add, no, you can please, you are most welcome. Thank you so much.
Thank you. Thank you, Sister Verity, for the wonderful sessions. Now I request Madam Premila for a few thoughts on this regards. Over to you, ma'am.
Thank you, Ma'am Nanuka Japaigo, for giving a chance to talk regarding this topic. And thank you, Ma'am Verity. You explained very well in the topic. I just want to add something regarding the reference. As definitions, we have learned that we have to be referred to the higher hospital, which is having a lots of facilities. And also refer, it used to do when once the person is stabilized in the higher, so they used to send it to the lower also, okay, according to the feasibility of the patient's party. And for example, children's for the CA patients, they used to send to the Tata Memorial, is in Mumbai. Then from there, after the stabilization, they used to do all the surgeries and all. Then after that, they will, if it is only for the chemo and for the some other investigations, they used to send to the Guwahati and all. Okay, so that also it's a refer. So then about the referral system. Okay, referral system, it may be from the hospital or it may be from the community. I think participants, maybe some of you are working in the community system also. Can you give the referral system of India in the PPT?
You want me to share?
No, it's okay. So the referral system, it is in the community, it is start from the it is in the primary, the primary health center to the community health center, like that. Okay. So in the before reaching to the primary health center, who are sending the patients to the primary health center, isn't it? So those who are ANM, ASA and all, they used to go for the home visit and all. Then if they find some problem, they used to send it to the a primary health center. Okay, if the primary health center, if they cannot get, and they will send to the community health center. So like that, the referral system is there in the community also. Why it is important, we have to be discussed in the when the patient is referred to the other higher. Okay, so it should not be a jump. Okay, so according to the usually we have to be see the what is the availability in the local instead of sending, because instead of sending the place, it may be a far, the persons may having a socio-economic problem and all. So to prevent that all things, we have to be find it out the local. Okay, what are the feasibility and what are the services available. Okay, we have to be try to find it out. And I just want to add regarding this IMNCI, and there is a before it was a IMCI. Okay, so UNICEF and the World Health Organizations, they have IMCI to the, they convert to the IMNCI, because neonatal it was not there, but in the UNICEF and the World Health Organization, they add IMNCI. So we have Ma'am Verity explain about the 3 trials. There is a pink, green, and a yellow. Then one more color also it's there. It is not showing. One more color is also it's there. There is a golden. Okay, golden part is mainly it is the counseling of the parents. Means like once the child is born in the any kind of healthcare facility. Okay, so they will see, they will assess in the symptom, like Ben said about, explain about the symptom, sign, about the nutritional status and all. Then they will try as the child. Okay, then if when we have to be referred when there is a urgent, it is the need if the child condition is a very severe. Okay, so before that we have to be explained, we have to be make understand the parents. Okay, that counseling part is there in the, it is in the golden part. I just want to clear only that one. Then the transfer. Okay, so there will be in 3 states. Okay, so it may be in the red, it may be in the yellow, it may be in the green. There will be transfer will be there. So Ma'am explain about the transfer of the stabilization. Okay, to refer we have to be referred after the stabilization, isn't it? We have to be do that transfer the patient. It may be intra, it may be inter. Okay, Ma'am explained very nicely. So in 3 level, I just want to say that in the 3 level transfer will be there. In the green, those who don't need to stay in the hospital, the things which can they manage at home, we have to be transfer them to the home. And those who are in the yellow means they don't need emergency, but it needs some kind of observations. Okay, they will be categorized in the yellow. So once they are stabilized, okay, then we have to be send the persons to the maybe 1-2 days. Okay, they will be observed, then they will send to the at home. Okay, so like transfer, it's not only the emergency. I just want to tell that. Okay, then the okay, now we have to be, yes, Ma'am explain about the effect of the adverse effect of the transportations. Okay, during the, we have to be find it out to prevent all the adverse. So stabilization is a very, very important before the transportation, okay, of the patients. I found some of the research which they have done regarding the barriers. Okay, many of the barriers will be there, isn't it? Some of the participants may be also you have some experience when you refer the patients from the hospital or in the community level. Okay, if I will be very happy if you explain, if you share about your experiences. What are the difficulties did you find when you transfer the patients? Okay, through the research, when I found some of the barriers. Okay, like when we refer the patients, okay, maybe they are either ideal state. State means it may be from one state to the another. Okay, so afar. Okay, then the second I found is the lack of adequate knowledge about the referral system. Okay, we don't know about the referral system. That may be a problem. Okay, that may be a barrier. And if we don't have good connections in the 3 level, we have primary, secondary, and tertiary, isn't it? Sorry. So if we don't have a connection in between, okay, so there this also one of the barrier. And another is a self-referral and the bypass the referral system. Okay, bypass means like that's why. So from in the community, first they have to go to the primary, then the okay, so like that. So they jump and they directly come to the okay. So this is the bypasses also. Okay, this is also a problem. And I found the most of the common barrier, that is the insufficient knowledge about the referral system. These are the barriers that through the research they found that during the referral. And some of the points also which I found that some factors which is effect, okay, it very giving effective in the implementation of the referral system. Okay, so they have given us 4 dimensions. That is the technology dimension. Okay, in the technology dimensions, they have given about the electronic reference system. If they have an electronic, okay, so it will be very fast. Then we can transfer all the data and all. Then coordinations in between the healthcare system, responsiveness and the appreciation of the feedbacks. Okay, we used to explain about the component of the reference, isn't it? For the receiver, for the standing and all. Okay, then are the feedbacks. What are the feedbacks? Okay, then in the second is the process dimension. That is the effectiveness and efficiency in the actions and the program. How much actions they used to take. Okay, as soon as they receive the patient. And the third is the organizational dimensions. There is the management, policies, rule and regulations and all. Okay. Then the third is the individual dimension. That is if there is insurance and all. Then if the center is if it is a patient center and all. Okay, these are the dimensions. Okay, if they discuss through the research, they discuss this is the most effective factors for the implementation of the referral system. Okay, these are the points I just want to keep. And the 4 measures I just want to tell that to all the participants that as we are nurse, we are working in the healthcare system. Always we have to be finding out the place, okay, in the healthcare system. We have to be finding out the nearest, okay, place. We have to have a knowledge about the availability of the manpower, then the equipment and the facilities, so that we can refer, we can help. Actually, we are not going to refer, but we can help to prevent the well-being of the improvement of the health well-being of the child, and also we can just help of the socio-economic of the patient's partner. Thank you.
Thank you so much, ma'am. Thank you so much for adding such a wonderful topic, and then adding other varieties of the topics. So if you have any queries related to the topic, I just wanted to request the participant to write down in the chat box, or even you can share your experience, because you are working in a remote place. Some of you are maybe working in a PHC, subcenter, tertiary. So you may have a variety of the experience. Even if you doesn't want to speak, you can write down in the chat box. Okay, thank you, Donika. Can you please explain about the mottling again?
Mottling? Discoloration. Okay, mottling is that when you have SS, okay, so this is a lack of circulation. So when you touch the feet of the persons, it's become a cool. Okay, there is a mottling. Okay, patchy discoloration. The color will be changed due to the lack of circulation.
Any other queries, or even you can share your experience, how you are transferring your patients? Because we all belong from the Northeast regions and we have a problem with the transportations. So you can at least share your experience, how you are transferring. What should be mentioned in the consent form before referral? Pramila have asked, ma'am, would you like to answer? Like what should be mentioned in the consent form before referral?
Okay, so this is the protocol. It may be a different, I mean, the hospitals, we have a different referral form of the NIGRIMS. Okay, we have in this form, we mentioned about the, okay, okay, so it's written about the name of the patients, then the at present where the patient is there. Can you explain that? Okay, where the patient is at present, okay, then to whom the patient is going to refer. What is the diagnosis? Okay, what is the reason for the reference? Then like it mentioned about the course of the treatment also. Then course of the treatment, then it will then it's also mentioned about the for proper identifications of the patients, including all the parents, then either the patient is an employee or not. Okay, everything it is included. The main thing is what is the reasons the patient is referred to their healthcare facility and to whom it is the main, and what is the at present conditions of the child.
I think consent form is depend upon each
It
different,
may be different.
yes,
That's why I said
institution wise. So if you want our consent form, I'll just click the photo and I'll share in the WhatsApp group. That is as per our this thing institutions, but each institutions will have a different consent form. Okay, but the main purpose and the content is like same only. Why you are referring, what is the reasons, so all those things, and the patient detail they will mention. Another is asks, like sometimes if the patient's attendant refuse for the referrals in spite of risks involved, in that case, ma'am, how to convince them?
Okay, so this is about the lack of knowledge. Okay, lack of knowledge. So first thing is that's why the ma'am explained about the process. She mentions about the objective of the referral. Okay, so our objective, it should be very clear. Okay, so through that objective only we have to be explained. Okay, for example, the child need a surgery. Okay, it is not available in the NIGRIMS, for example. Okay, so your main objective, it will be to get a surgery. Okay, so you have to be explained about the surgery, what are the process it's going to do, and how much it is cost. Okay, when proper explanation is very, very important, because once they ask about the operations, I mean, people is so scared, isn't it? And also it comes like in their mind that how much it will be cost, isn't it? So we have to be explained. You have to be give some options, not only one facility you cannot give. Okay, so many of the facilities, the services available, you have to be give, and which one will be the more effective. Okay, you cannot force them, but always you can give a option. Okay, so some facilities they are maybe having a waste, the cost will be more, isn't it? Services will be more like that. Okay, so we have to be choose some facilities. Okay, I mean the healthcare system, it is effective and the low cost. Okay, according to the the socioeconomic conditions of the patient. Not only the socioeconomic condition, even the manpower also. If the patient's party, if they don't have a manpower, maybe different, maybe the child is the mother having many children, isn't it? So no one is at home, isn't it? So these are the things also. It's so proper explanation is very, very important. You have to give a goal, aim, and objective. Then you have to give options. And it's depend on you how you're going to talk, how you're going to explain to the patient party.
Okay, thank you. Despite of ma'am had explained, no. So when I was working in Bihar, we also used to give training for maternal and child health. During that cases, sometimes we used to get the patients where, pre-eclampsia, eclampsia, and then we used to refer. But that time patients party, usually they doesn't want to go because of so many reasons.
Yeah.
So in that case, because all are adult and we can't force, as ma'am said. So in that cases, you can document, at least you explain from your side, do whatever you can do, as ma'am said, to give the so many options. And even though if they are not going, then just write down in the paper that after explaining all those things, patients are not willing to take. So you just make a documentation, get a signatures, and then just keep it, and you can do what you can do in your facility. That is the only things we have done during my experience. If anyone wants to have a better experience or what you are doing, you can write down in the chat box. Okay, so these are the things we used to do. Second question is, ma'am, can we ask? Rinja, you want to ask anything apart from the transportations, which is not transportations? You can ask. I think Ma'am Verity has nicely explained about the scene run. Like in scene runs, if any accidents and will happening, so nearby facility wherever is there, we will just refer the patient in that scenario. I think that is the one.
We take the victim to the
nearest facility. Okay, from non-medical to nearest hospital. Thank you. Lucy has also answered in the chat box. Another question is I have experienced that the neonate was granting, but that the parents don't want to refer. It's very scary sometimes, but I just give only oxygen. Yes. If the patients are not willing to take, what we can do, we can do our best to help in their survival. Okay, another question is like, ma'am, sometimes patients' parents refuse to referral and
Same.
how we convince him. I think you got the answers. For mentally unstable child who need referral, what protocols will be followed? Do you have any idea? Especially mentally ill child. I think for the mentally ill child also it's the same.
Same only.
Only thing is like consent we are not taking from they are taking from the legal guardians or from
But this
parents.
like a mentally unstable child. Okay, so unstable means children's
Psychiatric choice order.
Yes, I think in that cases usually we will take the legal guardians and the parents, but I think protocol is same. We have same in the degrees, no?
More or less same.
Same. Okay. If anyone have a better experience, you can please write down in the chat box. If the baby is not stabilized, so what we'll do? If you are referring without stabilizations of the baby, then chances of survival is much less as compared to yes. If as compared to once you will stabilize and then refer, at least patients will able to reach to the nearest facility. But if you are not stabilizing, that's very hard to reach. Then there is a higher, chances of these things, a revival of the patients, I guess. Well, we have lots of problem in referring and transporting the patients to the higher center due to lack of transport services, and patient refuse to go to the higher phase. It's most problem in rural area.
Yeah.
I think this is also a problem in the other area also. And yes, in rural area we have seen the most. So
it is mostly we got a problem in the especially in the government setting.
okay. If the patients die while transferred to another hospital, who will take the responsibility for it? Usually,
Okay, like if the patient is die on the way, that means that patient's condition will not be good. Okay, so maybe before the transfer, the patients must be in the party must be explained about the condition, isn't it? And that they used to take the written consent also. Okay, if anything happen, we are the, isn't it? They used to give. Okay, so that will be the responsible of the party, not the hospital.
and I think we do our best, before referring, we do our best. Then if something will
That's why
happen, then anyone wants to share, because most of you are working from the rural area. You want to share your experience in the group? I've not seen any more chat questions in our chat box. Again and once again, I request these things. Anyone wants to share your experience? You can write down in the chat box, or else we will stop. We have already 8 minutes over the time. Okay.